Okay, here we are on Chapter 30, Endocrinology. In this particular chapter, we're going to cover a review of the A and P, and I will go through that fairly quickly. I'll just kind of click through most of that. I'm not going to read it all out to you. I'll let you look at that as a refresher. And then endocrine disorders and emergencies. That's the meat of what I want to talk about today. So your A and P, remember your endocrine glands. They send out messages. They have systemic effects. So think of them like a key that is, or a messenger that's sending out to specific areas of the body to do certain things. Again, it may have single or multiple targets, and there could be disorders, as we know, that could be in extreme. So if we've got over or underproduction from these glands, then we're going to have various body tissues or organs that are going to be affected. Hormones of the hypothalamus and pituitary, just kind of another representation of the slide before. The anterior pituitary going to control some of that adrenal gland, thyroid, growth hormone for muscles, bones, prolactin for mammary glands, the FSH for follicle stimulating hormone, luteinizing hormone for the ovaries, and produces testosterone or estrogen, or has that effect with those hormones. And then your posterior pituitary, that's going to affect your ADH, your antidiuretic hormone in the kidneys, as far as when to release urine or produce urine, and then the prostate or uterus. So both those systems are affected from the hypothalamus. It's located deep within the cerebrum. Remember that if there's an issue with the hypothalamus, it's related to either disease, something that has been traumatic for that area, or something that's a congenital disorder, something that the patient was born with, possibly. You've got the posterior pituitary, anterior pituitary, thyroid gland, parathyroid glands, thymus, and to the pancreas. So this is a combination organ. The exocrine tissues secrete digestive enzymes into the small intestine, whereas the endocrine tissues secrete hormones. So you have a production of glycogenolysis or glyconeogenesis at each of these sites, depending on what's needing to be produced at the time. The pancreas also produces different types of cells. You've got your alpha, beta, and delta. The glucagon, it targets all cells. It stimulates hepatic glycogenolysis and glyconeogenesis, increasing the blood glucose level. So we carry glucagon in a form on our trucks. If we can't get an IV started and we need to get the patient's sugar raised, then you can use that synthetic, if you will, glucagon. Insulin, on the other hand, it's also, our target tissues are all cells. It stimulates cellular uptake of glucose. So again, that's why I kind of use that term like key that opens or allows that movement of glucose within the cell wall. It increased rate of synthesis of glycogen, proteins and fats, decreasing blood glucose levels. So insulin we give for the opposite problem, somebody that has too high of a blood glucose. And somatostatin, alpha and beta cells in the pancreas, suppresses secretion of glucagon and insulin with the islets of Langerhans. So you've got all three types of cells being produced by the pancreas. The alpha cells stimulate the release of glucagon and glycogen stores. Beta cells stimulate the release of insulin. Your delta cells produce somatostatin, and that inhibits glucagon or insulin. Your adrenal glands in the adrenal medulla, inner segment of the adrenal gland, it's closely tied to the autonomic nervous system, and we know there's sympathetic or parasympathetic. So the epinephrine is produced with the adrenal medulla, so the muscle, liver, and cardiovascular systems are affected, stimulates features of fight or flight, so that's sympathetic. You also have norepinephrine, which is the same areas or body tissues that are being affected, and it stimulates vasoconstriction. So So this is that kind of autonomic stimulus. Adrenal glands also corticoids and cortisol. Most cells, particularly white blood cells, it exhibits that inflammatory and immune responses. So it acts as an anti-inflammatory immunosuppressive agent. Mineralocorticoids, kidneys and blood, contributes to salt and fluid balance. So you can see where if you've got a problem with the adrenal glands, then you could have blood pressure issues, problems with the kidneys, and even relating to cardiac issues if you can't eliminate potassium or you have a buildup of potassium. And then we see other effects down lower related to male and female stimulation of their different glands. The gonads, for female, we call those the ovaries, males are the testes. And again, the difference on those hormones is related to sexual development and secondary sexual characteristics for males and females about development. Pineal gland, located in the roof of the thalamus, it's kind of the body's biological clock. Just like if you've ever heard the term sundowner, or folks that have issues with night and day get mixed up. This is kind of that where the body says, hey, it's time to go to bed, we need to recuperate day and night. So in paramedicine, if we're working the streets for EMS and we're working night and day, our body can get a little bit confused about night and day and when it's supposed to sleep and when it's supposed to be awake. So that can cause some additional difficulties for our health, being up all night, all the time. So melatonin, it's produced to help us sleep, may help us with that cycle of waking and sleeping. Certainly helps with putting people to bed. Other organs with endocrine activity, the placenta, digestive tract, heart, and kidneys. So disorders of the pancreas, thyroid, and the adrenal glands, and this is what I really want to get into today. The pancreas, we get into diabetes mellitus, and we may have problems with the metabolism of glucose. So if you've got insulin, it's the dominant hormone that's being released when blood glucose is high. So if you have a big piece of cake, your blood sugars will go up. The pancreas, if it's working properly, will send out the insulin to take care of that additional sugar and lower blood sugar levels. Glucagon, dominant hormone when blood glucose is low, so it will be released to try to produce or release more sugar from the body's tissues into the bloodstream. Is kind of a backup. So there's kind of a scale that's always being tried to teeter one way or the other with the body. So glucose metabolism, you've got anabolism and catabolism, different methods of metabolism there. Insulin is required to have that glucose metabolism, so you've got to have a pancreas that's producing insulin, producing that hormone to make it burn. So presence of enough insulin to meet the cellular needs, ability to bind in a manner to stimulate the cells adequately, and if you can't obtain that energy, the body begins to use fatty stores. So if you don't have glucose in the system, then you start to kind of eat on yourself, if you will, and use those fatty stores that the body has. And that produces ketones and ketosis, so it becomes an acidotic state within the body, and that's why we have diabetic ketoacidosis. Regulation of blood glucose, hypoglycemia, and hyper, so the two extremes. The role of the pancreas, liver, and kidneys all play a role there, and osmotic diuresis and glycosuria, so elimination of that additional acidotic state or sugar by urine. So type 1 diabetes or insulin-dependent diabetes is characterized by low production of insulin. So this is your patient that's going to need insulin on a daily basis to control their blood glucose levels. So basically their pancreas, their pancreas is not working, and at this point they're having to do insulin injections. If they have it untreated, they can certainly have multiple symptoms: polydysplasia, polyuria, polyphagia, weight loss and weakness. Untreated or non-compliant may progress towards ketosis and diabetic ketoacidosis. So it's for those folks that have a first-time onset or that know about it but just are not able to treat it properly. Those are the side effects of what they're going to have. Your type 2 diabetes, they may call it adult onset or non-insulin dependent diabetes. This is usually a hereditary or obesity issue. 90% of these patients are diagnosed with type 2, and it's a less risk of fat-based metabolism. So you're not going to have that fatty acidosis issue as much as you would with type 1. Less pronounced hyperglycemia, so these folks may go down, if you can say hyperglycemic, hyperosmolar, non-ketotic acidosis 5 times, I give you $5. But it's managed with dietary changes, oral drugs to stimulate insulin production. This is your kind of glucophage folks that will take that orally and watch their diet to make sure that they're not taking too much sugar on board. So various diabetic emergencies, your DKA or diabetic ketoacidosis. Patients either stop taking their insulin for whatever reason. They ran out of a prescription, or they've changed to a different type of insulin. Sometimes they'll have some difficulties with an adjustment. They could have an additional stress that's going on, either an infection, illness that's causing a different blocking of the glucagon effects or insulin effects. It could also just be a metabolism issue. If you've got a fever and you're sick, then you're going to burn things at a different rate, so that can cause some issues. So, but polyuria, multiple, having to go to the bathroom quite a bit and urinate, the warm, dry skin, mucous membranes, they may be experiencing nausea and vomiting. Typically, you see deep, rapid respirations, the Kussmaul's that we've talked about before. You'll notice a fruity odor or acidotic or acetone odor where they're actually blowing those ketones off, and you smell the sweetness from their breath. And then our management's fluids and insulin, so we don't carry that in the field, so we have to take them to the hospital and try to get them some insulin at that time. The HHNK acidosis, physiological stress can cause the issue, producing hyperglycemia there, and then you've got multiple signs and symptoms there, and fluids and insulin again as directed. So there's not much we can do in the field other than start an IV and monitor their cardiac. And then hypoglycemia, the other extreme, excessive administration of insulin could be a common cause. Excess insulin for dietary intake, so maybe a lot of times people will take their insulin before they eat, but then just not be that hungry, and then ultimately it ends up with a hypoglycemic state. Maybe they overexerted themselves, resulting in lower blood glucose levels. So this could be something that's kind of not typical. Weak, rapid pulse, cold and clammy skin, weak, uncoordinated. They may be irritable or agitated, decreased mental function, could be even into a coma or unconsciousness at that point. So we know to give sugar if they're below 70 milligrams per deciliter. Cardiovascular issues, respiratory, nervous, GI, and ocular, all those things are part of that diabetic emergency area. If you've got DKA, definitely a rapid pulse and low BP. The respiratory rate may appear exacerbated for air because they just can't catch a good breath. Trying to blow those ketones on, so the gas exchange may not be as good. Maybe a headache, restless, definitely a dry mouth, having to urinate quite a bit. So that's what your DKA is going to look like. HHNK may be very similar, and then your hypoglycemia. Generally everything's normal except for their mental capacity. They may be unconscious or confused or combative, and so look at those. I think we generally know how to obtain a blood glucose, so I'm going to kind of flip through some of these. Just make sure that you understand how to use whatever device that you use and obtain that reading. Remember your extremes. I think the lowest I've ever seen is probably 10 or 12 on a glucometer. Most glucometers, once they hit somewhere between 3 and 500 milligrams per deciliter, they just say high, so they won't even give you a reading past that. So if it's anything over 3 to 500, that patient's going to need to get insulin and be evaluated at the hospital. So make sure you record it. It's an important part of what we do in the street, especially before you give any drugs or sugar. Diabetic ketoacidosis. So body's change in fat metabolism. We've got a buildup of ketones, so we're producing acidosis within the body, and we know we're always trying to maintain that balance within the body. So if we can't get homeostasis, we've got an acidotic state. Extended period takes typically 12 to 24 hours, so this is something that's built up over time. It's not anything that's typically acute. Doesn't happen in an hour or two. They typically have a sweet, fruity breath, that acetone breath. They may have potassium-related cardiac dysrhythmias, so we're getting into that now in our cardiac course. So think about the relationship there between that potassium and the acidotic state and how it can affect the heart now. You may have the Kussmaul rapid respirations and a decline in mental status. So get your good sample, look for medical ID. If they can't answer you, look for a bracelet or necklace that may indicate what's going on. High flow O2, check their sugar. If you don't know or you can't obtain it, it never hurts to give 25 grams of D50. You can always have that changed at the hospital with insulin if you really can't get to that point. But it's not a bad idea to have your IV running and give them a bolus, maybe up to 500 cc's, 250 to 500. Monitor cardiac rhythm and vital signs, and then expedite your transport, because we really can't do much on the scene. Again, the definitive care for these folks is going to be an insulin injection. Hyperglycemic, hyperosmolar, non-ketotic coma. So type 2 diabetics, blood glucose levels very high, obviously 1,000 milligrams per deciliter, typically not going to read on our equipment. That insulin activity prevents the buildup of ketones, so sustained hyperglycemia, definitely going to be dehydrated because they're going to be urinating as much as possible and breathing off everything that they can. Could be as a result, you want to suspect your folks that have been through dialysis, that maybe have a recent infection or sickness, and possibly due to new or different medications. High mortality rate, so these folks are at danger of death if you don't get them to the hospital quick. Gradual onset again over several days, so just ask about history as much as you can. Increased urination and thirst. Definitely you see some orthostatic hypotension where they get dizzy when you stand them up or sit them up. Possibly altered mental status depending on where you've caught them in the midst of this episode. Maybe very difficult to distinguish from DKA in the pre-hospital setting. We just don't have the equipment to really check all that out there. It's going to be part of labs and some other things they're going to need to do at the hospital. But the treatment's going to be identical for you, so don't sweat that. Hypoglycemia, the other end of the spectrum, it's a true medical emergency. You're going to see this more than you'll ever see DKA. This is going to be pretty regular. I think I've seen this every week that I've ever worked. It's a low blood glucose level, rarely seen outside of diabetics. So it's you see some folks say, I need a Snickers bar, or my sugar's dropping. That's possible, but it's more typical or more common with your diabetic folks. By the time the symptoms and signs and symptoms develop, most of the body stores have been used up, so they've already kind of got to a point where they can't compensate anymore. Diabetics with kidney failure are predisposed to hypoglycemia. So just kind of an image there. Just glucagon, again, raises the blood glucose level. Insulin lowers the blood glucose level. So you're going to have an altered mental status. It's typically a rapid onset. So compared to DKA or that acidotic state, these folks develop pretty quickly. They may be combative as they're confused. They kind of revert back to their primal feelings, so they may be scared, and that's the first thing somebody does if they don't know what's going on is to fight. So diaphoresis, it can be very sweaty and tachycardic, possibly seizure and coma or blacking out. Assessment, again, get your history, look for medical ID if they have it, maintain the airway and high flow O2, get your blood sugar early, and get that IV access in as quick as you can. And it's important to make sure if you have IV access, again, for these folks, that it's patent, that the line's flushing well, you monitor the IV for just a little bit before you push any sugar, and make sure that you've got a large bore IV in place. It's very hard to push that sugar. If the IV can't be established, consider your glucagon to give that IM, and that will release some of the body's stores until you can get them to the hospital. Monitor the cardiac rhythm and vital signs, and then expedite transport. So again, maintain that airway and high flow O2 is going to help them a lot while you're doing your other procedures. Moving to the thyroid, this kind of just shows you the multiple stimulation loop takes place. Any kind of cold or stress activity, you have that thyroid stimulating hormone. It's released, you get negative feedback, and now we have hormones that are released into the blood system and have some reaction to that. So disorders that we have, your Graves' disease, probably hereditary in nature, so it's going to be something genetic typically. The thyroid is stimulated excessively to produce excessive hormones. So you have agitation, emotional changeability, insomnia, poor heat tolerance, weight loss, weakness. So this is an overstimulation of the thyroid, so this is going to kind of put everything in overdrive. Tachycardia, possibly AFib, as we'll talk about as we go down. You may have protrusion of the eyeballs or goiters that are located on the patient. Emergency calls usually arise from cardiovascular, so that's kind of what we get called in for more often than not, is chest pain or something related to dizziness or something of that nature coming from the cardiovascular. So manage what you see signs and symptoms wise. A thyroid storm or a thyroid toxic crisis is a life-threatening emergency, and it's usually associated with physiological stress or possibly an overdose of thyroid hormone. If a patient doesn't know any better, they may take extra to try to kill themselves. But results when the thyroid hormone moves from bound state to a free state within the blood. In other words, it's just kind of like a massive release of the thyroid hormone. Your temperature is going to rise extremely high, possibly up to 106 degrees Fahrenheit. Increased activity of the sympathetic nervous system, so you're going to see that irritability, possibly delirium or coma, tachycardia and hypertension, vomiting, diarrhea. So just very hot patient, very, just a massive storm there, if you will, and that's why they call it a thyroid storm. Support the airway ABCs, monitor and expedite your transport. There's not a whole lot we can do in the field other than manage the cardiac aspect of that and try to cool them down if we can. Hypothyroidism and myxedemia. This is your patient where they're on the other end of the spectrum and they've slowed things down. So again, genetic or possibly acquired. Sometimes I've heard of people having surgery or having trauma to the neck or the thyroid, and it results in this type of disorder. Any kind of chronic or untreated hypothyroidism moves to the myxedemia. So thickening of the connective tissue, infection, trauma, CNS depressants, or cold environment can trigger a progression to that coma state. So fatigue, slowed mental function, cold intolerance, constipation, lethargy, just a general absence of emotion, 1,000-yard stare, if you will, thinning hair, enlarged tongue, cool, pale, and dough-like skin, coma, hypothermia, and bradycardia. So just complete other opposite end from a thyroid storm. Hypothyroidism, just kind of a slow, they tend to gain weight, and it's just a slowing down of the systems. Again, your ABCs, monitor that cardiac and respiratory. We want to make sure that they don't drop into a coma state. get your IV access, but just run it TKO, and again expedite your transport. This is going to be treated at the hospital primarily. The adrenal cortex, just kind of a quick look there. Hyperadrenalism, or Cushing's syndrome, often due to abnormalities in the anterior pituitary. So that could be the issues we talked about earlier that could have been triggered. May also be due to steroid therapy for non-endocrine conditions such as COPD or asthma. So think of your folks that are already taking these steroids that may cause this as a side effect to taking those medications to help for another body system problem. Long-term cortisol elevation causes many changes, so could cause atherosclerosis, hardening of the arteries, diabetes and hypertension, increased response to catecholamines, hypokalemia, and susceptibility to infection. So you kind of get this moon-faced appearance, the swelling, weight gain. You may have a fat accumulation on the upper back, skin changes and delayed healing of wounds. So they may have multiple wounds that are just in different stages of repair. You may have some mood swings from one extreme to the other, and maybe impaired memory or concentration when you're talking. Support the ABCs. Use caution. If you're going to establish an IV, be sure of yourself and that you can get it. You don't want to open up a wound that may be hard to heal. Report any observations indicative of Cushing's syndrome to the receiving facility. Let them know that you're coming, and any special practices they need to do before you get there. Any kind of disorders of the adrenal gland, if you have an insufficiency, it could be an Addisonian disease or Addison's disease. So due to the destruction of the adrenal cortex, often related to heredity, so again this may be genetic, stress may trigger this crisis. Steroid therapy again could be a problem, and a sudden withdrawal can trigger an Addisonian crisis. So if you've had steroid therapy and you have asthma, then you could have an Addisonian crisis if they take you off prednisone or something like that. Progressive weakness, fatigue, decreased appetite, and weight loss, so generally look sick. Hyperpigmentation of skin, vomiting, diarrhea, hypokalemia, so not enough potassium or other electrolytes, which again could relate to cardiovascular issues. So that's why it's so important. I've talked to you guys in the cardiac class about our electrolytes with the potassium or sodium, calcium, any of those types of things that if we have other body systems that are causing problems with these electrolytes, then it can definitely affect the cardiac, and that's why we kind of need to monitor that now as paramedics. So ABCs, monitor that cardiac output and pulmonary status, make sure they're ventilated well and that they're able to breathe well. Obtain blood sugar and treat for hypoglycemia if that's an issue. Get your IV going, and don't be afraid to provide aggressive fluid resuscitation. If they tell you they have Addison's disease and you see the signs and symptoms and a low BP, then don't be afraid to give fluid, and then expedite transport. So look back over the A&P for this chapter, refamiliarize yourself with some of those areas. My focus is going to be, for this chapter, is going to be the actual disorders we discussed and the treatment in general that you're going to see in the field. I'm not so worried about the A&P portion of it as I am the identification and treatment. That's it for this week.